Call the meeting to order here. The affidavit of posting was posted accurately. Our roll call, Supervisor Kelling, Supervisor Smisek, Supervisor Gurath, and Supervisor Bailey are present. Before and as we rise for the Pledge of Allegiance, I just wanted to add, I know it's not on the agenda, but in light of yesterday's tragedy in Texas, I would just like to add a moment of silent prayer. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Our next order of business is the election of our vice chairperson. And I'd like to nominate Supervisor Kelling.
Thank you. I'd accept that.
Okay, any other nominations? Hearing none, I'd entertain a motion for unanimous consent. Okay, second. All those in favor?
Aye.
All those opposed? All right, congratulations. Thank you.
Chairman.
I'd entertain a motion and a second to accept the consent agenda.
Motion to accept.
Supervisor Kelling, Supervisor Smisek, second. All those in favor?
Aye.
All those opposed? So our discussion items today, we have the fortune of having all of our staff, or a lot of our staff from the department heads and such from Health and Human Services. And the first thing that I just want to touch on is our role as a Human Services Committee. You've all received that in your packets and gone through that. But just kind of as a reminder, I'm really looking forward to working with this fine group of supervisors as we represent the Standing Committee for Human Services staff. Per our training manual, a committee's role is to serve a legislative function, which includes providing oversight of the departments. The work of the board is accomplished through committees. And in our case, it's Health and Human Services Department. So while this is my first opportunity to serve as committee chair, I am confident that together we'll honor our role as defined. Are there any questions about that? Okay. I also am certain I'm going to need your grace as I work through learning the mechanics of facilitating our committee meetings. So bear with me. Our first overview would come from Julie Driscoll, the Chief Officer of Health and Human Services. Did I say that correctly?
Yes, you did.
All right.
So great. Well, thank you so much. I'm very excited for our new Health and Human Services Committee. Nobody on our committee has served yet for Human Services, so we're excited and honored for you guys to be helping to guide the departments and where we go with servicing the community. We are planning today to give you a 5-minute overview of each department or each area. Very short amount of information. What I will tell you is that the Health and Human Services Department is very complex, and there's lots of services and moving parts and staff and contracts and dollars that come in and out of our department. And so it does take time to get some depth and breadth of understanding of what we do. So today is just a very light overview to just give you exposure to our leaders and then also just the basics of the work that we do. In your packet is a lot of information, some information about the overview of human services, Health and Human Services. It consists of the Human Services Department, the Aging Disability Resource Center, Veteran Services, the Samaritan Campus, and then the Washington Ozaukee Health Department. First, we're going to have you just hear a little bit about Human Services specifically. Human Services consists of 3 divisions: our Behavioral Health Division, Children and Families, and Economic Support. Within Human Services, we have over 120 county staff, with an additional 20 to 30 contracted staff that sometimes are housed here in the county and sometimes housed out in the community. And our budget is about 28 million and some change. And so first I'd like to introduce you to Doug. I think he's up first. So Doug Fry is our Behavioral Health Division Manager. And he's just going to share you a brief overview of some of the information in your packet of what are the services that are provided through the Behavioral Health Division.
Hi, thanks for allowing me to do this. Again, my name is Doug Bryan, the manager, so I supervise the supervisors in the Behavioral Health Division. There's 4 distinct supervisors and 4 distinct teams. The first team that I'm going to go through, these are in no specific order other than alphabet, is Acute Care Services, or ACS, as we call it. This does mental health crisis and adult protective services. So mental health crisis is for people who are having a mental health emergency, and those staff either go mobile. Sometimes clients come into our building and we see them. We provide a crisis assessment really to determine a level of care. So is it inpatient, is it outpatient? If it's inpatient, then the next question is it voluntary or involuntary? So clients are either willing to go in or they're not, and they're dangerous and they meet certain criteria, and then we can put them in the hospital. Then there's varying degrees of oversight that happens from that point forward. Then the other half of that team is adult protective services, and those staff provide care to people who are in need of guardianship. So usually elderly people who have a progressive illness like dementia, Alzheimer's, that isn't going to get better with treatment, and they need guardianship or placement services because they can't take care of themselves. That is the extent of the adult or acute care services. The next team is called Community Treatment Services. There are 3 distinct teams under that umbrella. They're all case management teams, and they're varying degrees of acuity and intensity and severity of illness. Most of the services happen in the community. They help clients with what we call activities of daily living. So just managing their lives, getting to the grocery store, getting to doctor's appointments, making sure that their Medicaid is up to date if they have to reapply for Medicaid to pay for services. Just about anything you can think of. Staff will either assist with that directly, or they will refer to a community agency that can assist people getting some of those needs. We also have we have 4 prescribers. 2 of our prescribers work mainly on that team with our clients. One is Dr. Craig Shedeker, and then we have an 18 NP, Catherine Anderson, and they see patients in the office monthly, quarterly, depending upon the severity and other flexibility. So those services have been full, and all of our prescribers are part-time contracted staff. The next team is Lifespan, which is our term for outpatient housing. So it's what you would think of as just an outpatient therapy office in the community. People come to us, they get mental health psychotherapy in the office. We also have psychiatrists and a nurse practitioner who love to see some of those people as well. And there's also a medical assistant, which is similar to an RN or an LPN, and an RN on that team. Some of the medication that clients get is in shot form, so they have to come to us and we give those injections. We also do what we call medication assisted treatment, which is treatment for people who have a substance use disorder. So some of those medications are Vivitrol or Suboxone, to help people stay clean from substances. The last team is youth services. So there's it's kind of a mishmash of services in that team. Some of our youth services are contracted out through what is now called Milwaukee. It used to be called CNA in Milwaukee. that would be one of the case management teams. We also just started last year another specific treatment approach called DBT, or dialectical behavior therapy. And that supervisor oversees that team. It's an evidence-based practice that we use. And there's a lot of moving parts as Julie said to that specific treatment. And we need to have a lot of things in place to have fit out. So we're providing the service in the appropriate way. We're also adding family-centered therapy, and we're partnering with the Children and Families Division. You're going to hear in a little bit, targeting youth who are at risk of being placed outside of their home. So this is an in-home model, and we just started the training for that. We're hiring therapists, and they will go into the community, people's homes, and provide this service to the whole family to try and treat the family unit versus just the child or just the parents in their home. So we're excited about that. It's in very early stages. We've got 2 clients who just started getting this one. So we're excited about growing it. There's also something called CLTS under that team. That's Children's Long-Term Support. So these are youth, typically under 18. They can stay on the team past 18 if they're still in school, but it's typically children under the age of 18 who have some sort of physical disability or mental disability, and they have very specific funding from the state. So Sarah is the supervisor, she oversees those staff, and that's a lot of interfacing with community resources, authorizing services, or even assistive devices for clients so they can stay in their home. And it runs the gamut of those types of devices. And then in the summer, there'll be like cat camp for those clients that her staff can fund with state dollars. So there's lots of different pieces to be used. And then really quickly, I just wanted to point out some of our typical community partners that we partner with in behavioral health, which would be like local health systems like Freighter, essentially, or local law enforcement, countywide law enforcement is a really a strong partner we have in the community. We also partner with Elevate in the community, who does a lot of contracts with us and provides a lot of services contractually. We also have contracts with professional services from West Dallas, also known as PSG. Partner with NAMI, Carl's Place, and Youth and Family Project. So all of those, and that's just to name a few, there are several more, but just to get a feel for the breadth and depth of behavioral health and how far and wide it reaches and how we interface with people to get needs met as best we can. How was that? It was a lot of information.
30,000 that's exactly what we want.
Any questions? Comments?
Good, and so now I'd like to introduce you to Coral Klein. So Coral is our Children and Families Division Manager. She's just going to give you a quick overview of that division as well.
Hello, good afternoon. Like Jim said, I'm Coral Klein. I am the Children and Families Division Manager. Children and Families Division has about 30 staff who are mostly licensed social workers and are trained to work with families in their homes and in the community. All of our programs are statutorily required to be operated by a county human services department under either Chapter 48 or Chapter 938. Between all of our programs, and we have 4 main programs, and I will go through all of those briefly. We are serving right now about 127 families and about 172 children and youth. Our first program is Child Protective Services. Child Protective Services is responsible for ensuring the safety of minor children when their parent or caregiver cannot protect them from danger. We operate, which you may know as the Child Abuse and Neglect Reporting Line, where either the community or professionals who are required to report suspected child abuse and neglect can call in 24/7, 365. We run that on first shift, and actually Doug's unit runs that on second and third shift on weekends for us. So far this year on that particular reporting line, we have fielded 326 reports, and all of last year, 2021, we took 899 reports on that line. So that's a very busy and important function for us. We also conduct investigations of possible child abuse. If someone calls in and it reaches the level statutory level that we need to take action, we do those investigations and often in collaboration with law enforcement. Law enforcement, all the jurisdictions and the sheriff's department are just our strongest partners. Not only do they work with us on investigations, they basically come with us when we need them in the community to ensure not only the safety of our staff, but also the safety of our clients and the kids that we're serving. So far this year, we have opened 65 child abuse investigations. In 2021, we opened 125 investigations. So we're about 6 months in, looking to be about the same so far. If a case needs to be opened, a child abuse case needs to be opened for court-ordered intervention, it goes to the ongoing CPS program. That is, like I said, court-ordered case management services. We provide resources and support to parents to change the reasons why their child was unsafe and why we needed to get involved. Parents stay in that program working with us until their child reaches what we call legal permanency. That could be reunification, going back home. It could be guardianship to a relative. We have a lot of relatives who will take placement of their minor relatives, their minor children, grandchildren, nieces, nephews, to allow parents the opportunity to work on what they need to work on and keep the kids safe. Sometimes that comes to a legal conclusion in guardianship and also adoption. There are times when the children cannot be returned home and the parents' rights get terminated through a legal process. In ongoing services, we currently are serving 54 families within the county and 83 children. Like I alluded to, when the child cannot remain safe in the home of their parent or primary caretaker, we can legally place them outside the home into a home of a relative or a non-relative. This is our foster care program. We always try to find family or kinship first, but when we can't, sometimes we must use a non-relative foster home, which is a temporary place, we hope temporary place for kids to stay. We have 2 foster care coordinators who recruit new foster placements and conduct home studies for foster home licensure. Right now, Washington County has 47 licensed foster homes, 15 of which are relatives or kinship. So kinship might just be, a family friend that has agreed to be licensed to take in a godchild or something like that, not a legal relative. Our next program is Youth Justice. The Youth Justice Program is responsible for community safety, for holding juveniles 11 or 17 accountable for their behavior that has resulted in contact with law enforcement. This has historically been known as juvenile probation. We don't call it that anymore, but that's how people know it. Social workers focus on connecting youth with mental health treatment, positive community supports, and work with the whole family on issues that have likely resulted in breakdowns in communication, family dynamics, relationships, things like that. But Doug had said around family-centered treatment. That's a joint venture on our part. I wrote a grant specifically for this youth justice population, kids who've been involved with law enforcement and on an order and at risk for going outside the home based on their behavior and mental health needs. So we're very excited about that program for this population. Youth are typically on this order for 1 year. If they successfully complete their supervision and do not get any charges, they're usually done. It's not always the case, but we sure hope it is. Right now, we have 89 youth on supervision. We contract with Justice Point on community service and restitution program, which of course are court-ordered outcomes or consequences. Kids may have to do community service for a crime they've committed or pay back restitution to a victim. In addition, we have a shelter and residential treatment center here in Washington County called Riverbend Place. We partner with Norris to run that particular program. Youth shelter is when the youth shelter is used as the temporary place for kids to stay when they cannot be safely in their homes due to their own behavior. And when youth have mental health treatment needs that cannot be met with outpatient therapy, they may stay actually at Riverbend Place. The average stay is about 4 to 6 months. It can house up to 17 youth, both boys and girls can be there. It's arranged kind of in the old school pod sort of arrangement or halls. So they can move kids around based on how many boys are there, how many girls are there, and what the needs are of all of the youth that are staying there. In 2021, the shelter served 20 kids, and the treatment program served 6 of our kids and 3 out-of-county kids. They're also able to take treatment kids from neighboring counties. Our last program is sort of unique. We partner with Washington County Family Court Services, so the family court program over on this side of the street, as we like to say, to provide 2 part-time social workers to conduct court-ordered home studies on parents who cannot agree on custody and placement when they're going through a divorce. These workers conduct home visits and write a report to the court if the judge orders it, and then they are considered expert witnesses at trial to testify to their findings. We are currently serving 20 families in that program. And as Doug listed, a lot of our community partners, we work very closely with a lot of the same folks besides law enforcement and schools, friends, Crossville, Bay. I mean, pretty much all of the nonprofits and agencies within the county we work with in some way or another and connect our families with when we need to. So maybe that's for another meeting. We can talk all about our community partnerships. Any questions? Yeah.
The River Bend home, is that the one here on campus?
Yes, it's just on the street, other side of the fields. Yep. Previously known as Washington County Treatment Center. So
That's why
yeah, so
I was
I should
like,
have
wait a
said that.
minute.
Yeah,
Are we talking about the same?
we are.
Okay.
Yeah, we rebranded and got a new contracted provider in 2020, late 2019 and into 2020.
Thank you so much. And then finally, I'd like to introduce Renee Zabel. She's our division manager for economic support.
Good afternoon. I'm Renee Zabel, Economic Support Division Manager. I have 4 programs that we administer. We administer food share, medical assistance, childcare assistance, and CTS. I'll go through the programs and then I'll kind of go through how we run things and how we're divided. Food share is when to assist families with purchasing food for a healthy, good health, and everything is economically based, so you have to be economically eligible for all of these programs. The Medicaid is going to give medical assistance. The Medicaid, elderly, blind, and disabled is one group that we break it down into, and the other is foster care, which is going to be for the families and for children. We also have the child care, which provides a subsidy for child care for working parents, or sometimes it's students or people that are job seeking through ESSA. They can also get the child care. And then we also have a caretaker supplement, which is a cash payment for people that are receiving SSI, for parents that are receiving SSI. They may get a cash payment. That's pretty much the only cash payment program that is out there right now that we administer. W-2 is another program. But Washington County has formed a consortium, formed about 11 years ago, that we now are partner with Ozaukee County, Fond du Lac, Walworth, and Waukesha County. And that's when we're in this consortium. And in that consortium, we do have a call center. So I could be, or Washington County resident calling into the call center, and then get somebody in Waukesha County that's answering my call. We staff that with about 38 people a day throughout the 5 counties. Last year in 2021, we took about 96,000 calls in that call center. So it's a lot of work. There's a lot of things going on. And while you're taking the call, you will be sitting in your desk right in Washington County and answering the call. You know, it's not, some people think a call center, you're actually going to a location of a call center. It's just somewhere at your desk. So we can work on a number of counties cases and the same. We get the, you know, they can work on it. Numbers are a little overwhelming. Washington County currently has, this was April numbers, about 10,523 cases. So that would be 10,523 households that are receiving some sort of benefit, those programs. The medical, 9,752 have some sort of medical assistance on. And then we have 3,600 that are receiving food share. So you might have families that are receiving both medical assistance and food share. Childcare, we do about currently we have about 262 cases that are under childcare. Then CTS is just a handful, that's about 15. But like I mentioned, everything is economically based. You have to be economically eligible. So when they may call into the call center, you can apply online. You can stop into the agency. We get the information. If there's anything that's questionable, then we'll be asking for verification pay stubs, residency, just a number of different things. And they can upload that off their phone, send it on. It's a very technical thing now, that people are doing so much on their phones. And so it's making it as, accessible as people can get. I have a staff of 20 economic support. And then we divide that into what we call the elderly blinded disabled unit, which will house those cases that have nursing homes, different things that we're looking at for the medical on that. And then we also have the family, which would be the families with children under 19. Any questions? Yes.
So, recently, with the sudden economic downturn and inflation, are we already seeing results of that in case management?
Yes, I have our health, some numbers from April of 2020. Our caseload totals were 55,000 as a consortium. 55,000, they're now up to 70,000. So about a 20% increase. And for Washington County, they were 8,000 in April of 2020, and they are now 10,500.
So consistently a 20%.
20%
to this
consortium wide and county wide.
So I think we need you as a committee to keep that in mind for the next coming year or two. If we do get a recession, which I strongly believe we will, that this number is only right now could quite conceivably skyrocket as we've seen. So just something to keep in mind for the future.
And you're able to manage with the staff that you have come.
So far, yes. Yeah. Yeah, we've been doing a good job and a nice job of that. We've had, we're lucky enough to have a really dedicated staff that if something can't be done in this unit, can be picked up in this unit and the consortium helps, because then if somebody's down, if we were to lose a couple workers to FMLA or leave or something, then it can be picked up in another building temporarily.
We have through UW Extension, we have food educators for nutrition. We used to call it SNAP. I don't know what to call it now. Do you dovetail that with your food share program?
We have reached out many times to, they like to get our information and our, income limits and what different programs are out there for them. And we send that. Sometimes we have her, I don't remember the woman's name that is running it now. Used to be yeah. And she would come up and address her units and talk about that. So, because a lot of people will get the food share, but they need that education on what should I buy to make it healthy.
Any other questions?
All right, thank you.
And before we move on to the next discussion item, I did want to introduce Sandy Hopert. She's in the red. Back there, Sandy's the deputy director for human services. So she helps make all the magic happen. We're not making her present.
We covered all of these human services. Before we move on, it probably would fall under Doug, I'm guessing. I just had a question about opioid settlement and how is that being dispersed, and do we know a lot about that at this point?
Yeah, I mean, it's a great question. And we're a little bit remiss in not touching on that. One of the services that comes out of behavioral health is substance use disorder services. As you may know, about 2 years ago, we implemented Washington County's first drug treatment course. And we also have several diversion programs to help people get treatment and stay out of the criminal justice system. We partner with Elevate on those programs. We also have, in the last 2 years, implemented medication-assisted treatment out of the Human Services Clinic, so people are able to get access to those medications. And we do have grant dollars to fund those medications if someone does not have insurance. It's very expensive. It's about around $1,000 an injection. About a year ago, we brought forth to the county board a community survey that we completed in preparation for the opioid settlement dollars that we know that we will receive, to help sort of guide the conversation we'll be having when we receive the dollars about how we spend those. At this point, the money is still at the state level, and they are working out through WCA how and when that money will be dispersed. There is a call coming up on May 31st with WCA to sort of talk about where they're at with that. And I know our finance director and our budget policy analyst, Aaron Dahl, are keeping their fingers on the pulse, because we're eager to start doing some work with that. But that will be a very large task for this committee over the next several years as we plan with the community on how to disperse those dollars, because that does have to be approved at the county board level when we do spend that money and how we spend it. So that would be a very important task that we will be needing to undertake.
Two questions, actually, Julie, seeing as we're finding out everything today. How's staff do? How are we on our staff? Everybody has a shortage of people, and I'm sure we probably suffer from some of the same things that every other business do. But as you see it right now, are we way under what we need? Are we looking for a few people? Are we good? Where are we at?
Yeah. Overall, we're doing pretty good. Obviously, we've had our fair share of people who've been recruited by other counties or have found great opportunities. We've done what we could to try to keep people, and we've been successful in a few spaces of trying to meet what they were being offered, especially if they were a high-performing employee. We have lost some staff. I would say for the most part, it's not atypical for what we see every year. One of the areas where we're experiencing a little bit of pain is with our therapists. So we did lose all of our therapists last year out of the clinic. They were primarily all recruited by Children's Hospital, and who are starting to co-locate therapists in all of their primary care clinics. We have some really great children's therapists who are very eager to do that, and they pay them some great money. So we're pleased for them. And so that has been an area where we still have some vacancies. We have adjusted our recruitment strategy in that we are hiring what we call therapists in training, meaning that they have their master's degree, but they don't have their 3,000 hours yet to get their clinical licensure. And our staff, because they have the supervisors all have clinical licensure, and Doug does as well, are able to supervise their hours. It's a lot of more work on the supervisors to be able to be supervising those hours. But it has been what we needed to do to be able to recruit, therapists. And then we're hopeful, right, that they work for us for a couple of years, we supervise their hours, and that they continue to stay with us. And so that is our strategy right now. It also doesn't help that then we started another program. The Family Center Treatment Program requires therapists as well. And so that was 3 additional therapists that we're trying to hire for. So we lost a bunch of therapists and then we added positions. So, but we're making progress. And, it's also because we want to hire good people who just want to get the warm body. And so they don't come in as fast as maybe another position.
Very good, thank you. And this is more of a statement, but to the committee as well as to you, Ms. Driscoll. We did the opioid settlement, which somewhat mirrored the anti-smoking settlement of the tobacco settlement of back in the early 2000s, late 90s. If you remember, a lot of the money from the tobacco settlement ended up going into the general coffers instead of going for the intended programs that they claimed in the lawsuit where they should win. I want to make it known here today to the committee and to you, Ms. Driscoll, that I am against any of that money moving to anywhere other than where it should specifically go, which is mostly treatment and prevention, whether that be law enforcement or human services. That's where I want to see it go. And we'll be a very big proponent of that. Should anybody make a move to try and put it into the general funds or spend it in places that it shouldn't be. And I do also take in mind the children of opioid addicts and the many costs that arise from that, the housing and all the rest of that. That's something that people don't think of. There's a lot more victims than just the people who are addicted to the drugs themselves, but the children of these people who end up in foster care or in a situation where they require a lot more of the county's resources. So I think we do need to protect the money that we have from being used in any other way, but to make sure that it properly is used. So that's my statement to the committee and to you. Thank you.
Other comments, questions? Services, okay. The next item of duties and responsibilities of Veteran Service Department. Kurt was unable to attend today, so we will be hearing from him. We'll put it on the June meeting agenda. So that means we can have Tammy up next from ADRC.
Good evening. I'm Tammy Anderson. I'm the director at the Aging and Disability Resource Center, also known as the ADRC, but I'll try and stay away from the acronyms tonight. So the Aging and Disability Resource Center, we provide, we like to say, a one-stop shop for sources of information and referrals and resources. So our target population is adults with disabilities and those that are aging. So really anybody 18 all the way through end of life is our target population. We can take calls for anything as simple as, somebody looking for a phone number for the Social Security office, all the way to a lot of our calls regarding, mom can't live at home anymore and she needs to move into an assisted living, and we help people work through that process. So I'll just go through our core services. The bulk of our services are provided by information and assistance specialists. So those are the staff that are really taking the intake. They're kind of the first line of contact. And like I said, might just be giving out a one-time resource all the way to working the process of moving mom into that assisted living or potentially accessing public benefits. So we are the access point for publicly funded long-term care programs. If you're unaware of what those are, I can go into a little more detail maybe at a future meeting, but maybe you've heard of family care, community care, partnership, those sort of things. So those programs assist in paying for long-term care services for elderly people. We have 2 benefit specialists in our department and 2 benefit specialist assistants that help with these programs. So one of the benefit specialists is helping those that are 18 to 59 with all things related to Medicaid insurance benefits, and the bulk of her services are related to applying for disability and then also the reconsiderations for disability benefits. And then those 60 on up, all things Medicaid, Medicare, insurance benefits, drug care plans, appeals, those sort of things. So all of the really icky and sticky insurance things that people need assistance with, our department helps with that. We provide the senior dining program for the entire county. So we have 7 senior dining sites. Those sites provide a congregate setting in which people can come to the site and eat. And then the bulk of that program is our home delivered meal service. And we're right now delivering about 250 to 300 meals per day to homebound elderly people throughout the county. Those meals are delivered by volunteer drivers. None of our drivers are paid. And so the food comes to the site. We have a meal site manager there that packages up all of the food. The drivers come to the site, grab that packaged food, and then deliver it out to all of the homebound seniors in the county. We have a variety of health and wellness programs. So we collaborate with senior centers and community centers throughout the county to provide some of those services, as well as some of the staff in our office who are providing prevention and wellness classes for those that are 60 and older. So things such as we've done strong bodies, dealing with chronic pain, dealing with chronic conditions such as diabetes, some more of those preventative health and wellness classes rather than the reactionary upkeep of that disease management. And then lastly, our dementia and caregiver support. So we have a dementia caregiver support specialist. She is assisting people that are dealing themselves or dealing with a loved one that is suffering from Alzheimer's and dementia, connecting them with resources, and then a huge support given to the caregivers of the county. So those people that are caregiving for a loved one at home or in somebody else's home. We do a variety of events throughout the year for caregivers. So just today we had what was called a Confident Caregiver Conference out at Marine Park Technical College, really teaching caregiver skills, reducing stress, a variety of vendors that are there to help provide resources. And within that program, we also manage a few pots of money that can help pay for respite care. So we pay for a caregiver from an agency to come into the home so that the caregiver that is burdened can have a break from those caregiving responsibilities. So super high level, 5-minute overview. Any questions that I can answer?
I'll just follow up on your last comment about the respite care. I was a little bit familiar with that from personal experience with my mom in Waukesha County. So you mentioned that we pay for that. Is there a needs assessment done or?
Yes.
Okay.
Yeah.
Okay.
Yeah. Form we fill out requiring, a certain amount of need for that funding. It is limited funding. We do have some additional funds this year, probably carrying over into next year with some ARPA dollars. Typically, about halfway through the year, we do have to say, I'm sorry, we're not taking any further referrals. This is limited time.
Sure. Okay. And then as far as the dining centers, I was interested to see that 7 sites.
Yes.
The brunch you mentioned today is mainly the, like we used to call it Meals on Wheels.
Yeah.
Okay, so where are the sites, the 7 sites, and what kind of interest is there? How many people show up at these sites?
So we have, our sites are in, I'll start in the north, Kewaskum. We have 2 in West Bend, 1 at Meadowbrook, which is a subsidized housing unit. 1, we partnered with a church, Fifth Avenue United Methodist. We have 1 in Slinger, 1 in Hartford, 1 in Germantown, and 1 in Jackson. So West Bend, the Fifth Avenue United Methodist Church, that is our largest site. We're doing about 100, a little over 100 meals out of that site every day, the bulk of those being the home delivered meals. That site used to get about 20 congregate diners. With COVID, we obviously closed all of the sites. We reopened in late summer of last year. And then when things kind of spiked up in January, we temporarily closed a few of them. And then they're all fully reopened, but we are certainly not seeing the numbers of people that we were previously. The state has also put into effect, if you do not qualify for home delivery meals, so if you are not considered homebound and there's a needs assessment for that, you can get a carryout meal, which was previously not allowed. You were either a congregate diner or you were a home delivered meal participant, or you were finding your food elsewhere. So they are allowing for the carryout meals. So we're seeing a lot of the people that used to be congregate diners really come in and pick up their meal and take it home. And we're not certain how long that will last. If that will be something that will be forever, or if that will be something that will, when the public health emergency ends, that will go away with it as well. So the congregate sites are not hugely attended, but we are seeing people coming back, which we're excited about. Yes.
These meals that they're doing, specifically the congregate, I understand, people at home that are shut-ins, but the ones that are actually congregating. Is that a needs-based, or is this more of a communal type?
So we are at the point in Washington County where we have been able to serve people that are interested in the congregate program. If there is a point in which we cannot serve all of the people that are requesting it, then we would move to more of a needs-based assessment, or those that are at higher nutritional risk. So historically, I've been with the ADRC coming up on my 6th year. We have not had to make that move. We also have not really had to have a waiting list. Sometimes we have to pivot, figure things out. Our Germantown site got pretty large, and we contract with interfaith caregivers to deliver our more rural route. But at this point, we are able to serve everybody that has wanted to be served.
And the reason why I asked, just to understand, is not because I don't want to take care of the people that are shut-ins, the poor people. I do understand that with the elderly population, one of the biggest things you have to overcome is loneliness and depression. And these congregate programs bring people together and give them something to really strive for. So I do believe it's very important, but I would just want to make sure that, see where we're at and kind of get a sense of what you guys are doing.
Well, in a future meeting, I'll tell you all about the social isolation program I'm working on as well. So-
Great, love to hear. Very good.
Any other questions, comments from Pam? Thank you very much.
Thank you very much.
And next, we have the responsibilities and duties at Samaritan Campus in Taya.
Is this on?
No, you gotta just use your outside voice.
My name is Taya. I'm the campus administrator at Samaritan Campus across the street, which consists of Samaritan Health Center, which is a skilled nursing facility, also known as a nursing home. And then we have the fields, it's all connected, and that's the assisted living facility. So kind of from top to bottom, it goes from our Samaritan Health Center is a much more of like a clinical model. And you might hear in other presentations it being called a SNF, which stands for Skilled Nursing Facility. But it's a very clinical model. So all of the care of the residents are overseen by a primary physician. Their conditions are a little less stable. For example, maybe like your chronic diabetes or your congestive heart failure. So if there's ever anything out of parameters or a change of condition, the nurses are notifying the primary physician. And the primary physician comes every 30 days for the first 60 and then every 60 days thereafter. So in the skilled nursing facility, we have kind of two tracks, so to speak. We have our short-term rehabilitation, which is your, 3-day qualifying hospitalization, funded by Medicare Advantage. And the primary focus of this is maybe they had a surgery, a hip replacement. These days, we're seeing less and less of the knees and the hips. And it's more like clinically complex to kind of give them, rehabilitate them. And our social services helps with discharge planning to make sure they have any DME they need, any, home health, that kind of stuff, so they can successfully discharge home. So that's very in and out, short term. Then we have our long-term care, and that's more the management of, we might have our different types of dementias, our chronic diseases, whether it be neurological, a lot of diabetes. We also do tube feeding, wound care. Our CNAs are assisting with any activities of daily living, the bathing, the toileting, eating, all of those things. And we also have therapy services, contracted therapy services on site, PT, OT, and speech. So for our short-term rehab residents, that's very crucial for them. But additionally, our long-term care residents, they can help with bed mobility, or maybe they're getting a little more weak and helping them to, maintain their strength. The revenue sources are Medicare Advantage, Optum, Medicaid, family care, hospice, and private pay, some pay privately. So we are an enterprise. That's what I was gonna say. So we have our expenses, but then we have our revenues coming in as well. The Fields Assisted Living, that's more of a home-like model. So the assisted living facility, that's kind of like the umbrella over, and then you can see we have a CBRF, which is a community-based residential facility, and then we have the RCAC, which is the residential care apartment complex. Those are they're different, they're licensed separately. The CBRF is a little bit more dependent, and then the RCAC is a little more independent. So the CBRF is, we have 31 licensed beds. And like I said, the SNF was more of a clinical model. The assisted living, for example, it's not overseen by a physician. So it's just like if you were at home and something came up, you would contact your doctor and set up an appointment. So the CBRF, it's like a studio with a bathroom, whereas your RCAC is more of an apartment. So it's got a kitchen in there, there's studios, and then there's like 1 bedrooms. There's 24 licensed beds in the RCAC, and in order to admit to the RCAC, you must not have an activated power of attorney. So you must be what we call your own person. If you admit I'm my own person, and then down the road I need to activate my power of attorney, that's okay, but it must not be activated to admit. For our assisted living, we have our revenue sources are private pay, and then the Medicaid MCOs, like your family care.
Well, just one quick question. What is the balance of private pay versus?
I can get back to you. Oh, I've got my business office manager here, so.
Yeah, it's about half and half. A couple of years ago, the CBRF was very heavy family care. I think we only had 4 private pay people out of 31. But as people have left, we've gotten more private pay, so both facilities are about half and half.
So you can see the different departments. So these are for the skilled nursing facility. We take kind of a holistic approach, whether it be short-term rehab or long-term care, to make sure that their needs are being met clinically, psychosocially with our social workers. Their leisure needs are being met with therapeutic recreation, dining, that we're meeting all of their dining, and we have an on-site clinical dietitian as well who's a part of the team. We have our plant operations, our maintenance, who's taking care of the building, fixing things, putting up pictures for the residents, overseeing the preventative maintenance, all of that stuff. And then we also have contracted housekeeping, who's cleaning the rooms and keeping the building clean. And last but not least, health information. So it's a we call it interdisciplinary team, really trying to have a person-centered care approach and meet the residents' needs. This is what we call a continuum of care. So, the Samaritan Health Center, the nursing home, is the much more, dependent, and it kind of works its way as dependent to independent. So it can go from short-term rehab, maybe the resident can't return home. Perhaps we have an opening in our RCAC or CBRF that's more suitable for them. And at the same time, as residents, you might start in the RCAC and then you need more care and go to the CBRF and then into the nursing. So that is all I have. Do you have any questions? Yeah.
Sorry to be such a, but there's some things worth pointing out. And the other, so let's get back to enterprise. For newer supervisors, can you kind of explain what an enterprise fund is and why do we have an enterprise? What is it?
Yeah, basically, some county departments, you have expenses, but you don't really have the revenues coming in to balance it out. We, as an enterprise fund, we have our expenses, but we have these revenues, whether it's from insurances, private pay, residents, et cetera, coming back in. So currently we're not on the tax levy.
So that's what I feel is important for you to understand. This is almost like a private entity.
Like a business.
Yeah, like a business that the county is running. So it's not necessarily connected to the tax levy. And that will probably come into play in the very near future when we're talking about the Samaritan campus and the viability and stuff like that. We want to know exactly how these funds are working and just what the impact has been to this point and where we expect it to go in the future. Very important.
Just a question about the more complex patients on the LTC side. You mentioned tube feeding and things, patients of that kind or residents of that kind. Do you also have patients that are on vents?
We do not have that.
That's another certification.
That's a
or
special,
license.
yeah.
But I just thought I'd ask. Any other? Okay. Thank you very much, Dale. So that brings us to Matt, our update on speaking of.
Speaking of.
So as you know, the conversation about the future of Samaritan has been a conversation on the board and committee level for the last couple of years. And we did apply for a grant that was unsuccessful with the state of Wisconsin. And so we've been having to pivot a little and come up with what our next plans are, and we're in the process of doing that. So Matt Furno is going to give you an update on where we are and some of our next steps.
Okay, thank you very much. Good afternoon. And you did receive a committee report, and that was a quick summary of the situation as we look at it. What I'd like to do is, first of all, talk about there are 4 skilled nursing facilities in Washington County. Samaritan is a licensed 131 bed facility. We are currently operating with only 75 beds, and I believe the census is somewhere in the 56 range.
Yeah.
She moved. Who told you to do that? Okay, well, that's better because I have to vote. Yeah, okay. I didn't hear the music stop. Okay. Then there's Cedar Communities, and they have a 90-bed licensed facility. And I'm not certain how far they downsize on a temporary basis. What you're going to find is the nursing homes across the country are downsizing. And one of the biggest drivers is the fact that you can't find staff. And you had asked that earlier about staff. And so that is a major concern. The third nursing home is in Germantown, and that's Virginia Highlands. And they are licensed as a 121-bed facility. And I'm not certain how low they're operating at this time. And last but not least, or did I name all 4? Well, yeah, the Pavilion at Glacier Valley, and that is 106 beds. So when we did the initial study or the latest study, and that study has data that has been compiled in 2020, 2019, and 2021. Before we come back to you with a recommendation, we will update our study with Wipfli so that we have more current information as to the condition, what the market is, as well as the expenses of construction, the expenses of operation. Now, you had a chance in your packet to see the task force that we had put together and the results of that task force, as well as the Wipfli study and presentation. I'd like to also tell you that as of today, out of 72 counties, there are only 33 counties with skilled nursing homes. In fact, with that study we had, I believe it was 37 at the time. So nursing homes have decided to close shop county facilities. Today, we have 348 skilled nursing facilities in the state of Wisconsin.
Those all county,
No,
just total?
no, counties are only 33,
You just said.
only 33. Good question. Keep in mind that the county is not required to have a skilled nursing facility. They're not required to have a CBRF. They're not required to have an RCAC. We currently operate in the neighborhood of about $1 million supplement from SP or supplemental payment. And that is strictly generated from the bed tax for skilled nursing. And then the feds match that bed tax, and then nursing homes receive a portion of it. And that can fluctuate. I'm not sure what we'll be receiving this year in 22 is based on direct care losses in the previous year. Usually we receive it in 2 payments. And we've received at times, I believe 1 year, three payments, and that was like 800,000 a payment. And that was well over the $1 million. And years ago, we were averaging somewhere between 1.2 and 1.4 million. And that helps us avoid a tax levy. Yes, sir.
Is that federal or is that a state?
It's we have a bed tax, so per patient day, there's a bed tax. And then we get those dollars and the feds match it. And so we get half from the feds, but we receive a very small portion of that total amount. The Teachers Association and other entities receive those dollars as well. Originally, when we set this up, and that had to be in the early 90s, the plan was 100% would go to county facilities or governmental facilities. But of course, we didn't have control. The state decided. So if that would change, that would help us immensely. One thing about Title 19 or Medicaid is that up to 2021, we were averaging in within the bottom 5 states in the United States for reimbursement. Today, they've given us a boost, and in 2021, we are within the bottom 10 states. So this is one of the problems that we have in the industry with Title 19 or Medicaid. Yes, sir.
Why? Why is there that disparity?
Wow, that's a big.
Well,
It's a question for the federal government.
I believe I am sorely disappointed with the state leading age association as well as the national leading age. They have not represented nursing homes in general well. Secondly, the state of Wisconsin has the propensity of pushing for services from the home rather than facility services. And therefore, they have not funded their program well. And that's been historical. We've had problems since I've been in the industry, and I've been in the industry 30 plus years. Okay, so what are we doing today? Under the direction of our county executive, we have a team of Josh, Julie, Taya, and now a new member, Lonnie, we're looking at the situation and looking at the different options that we are exploring to be able to come back with a recommendation. Those options are, one, still seeking a partnership, and we do have another potential that as time goes on, we'll disclose and hopefully something will materialize from that. The second option we're exploring is a possibility of another federal grant. The first federal grant that we did not receive was that federal or state grant of 10 million would have helped us along, and we probably would be getting ready to build. because out of the proposed at that time was $31 million, to be able to have 10 million, that would have helped us extremely. And we would have been able to cover the rest of the cost through reimbursement. The other pieces we're looking at, one, renovation of the Samaritan Health Center, and that comprises of the skilled nursing as well as the CBRF. And in the study originally, in, I believe, 2019, our facilities department, Kara Herdrich, she did a cursory review of what was needed and came up with something like 4.75 million for Samaritan. Today, we're guesstimating somewhere between 6 and 10 million. The next option is to do a total replacement, and this is something we've talked to the board about in the past. And that is a 48-bed skilled nursing facility along with a 32-bed CBRF. And these would be 16 unit or bed units that would be convertible. In other words, we would start off with our population of residents in the skilled and in the CBRF today, 56 and 28 or so, and probably have 3 skilled nursing units, 16 beds, and 2 CBRF at 16 beds. Yes, sir.
In that scenario, would you keep the fields as well?
The fields, yes. We're working on being able to raise the health center while maintaining the RCAC or the fields. And that's 24, and the census usually runs very high, 23.
Typically full.
4. So we're doing very well there. Then another option in trying to, with the option of 48, 32 and 24 RCAC beds, we were estimating about $500,000 a year of tax levy support. With the current status of the struggles with staffing and the reimbursement falling short, it could be much higher. What's happening today is there is such a separation between what we're paying our employees, especially direct care. We have a $6 additional bonus per hour for them to retain them during this time of uncertainty, whether or not the Samaritan will stay in business. So it's a very tough situation. And anyway, so to offset that, we're looking at the possibility of maybe going to a 16 to 32 bed skilled nursing and possibly a 32 bed CBRF, and then 30 to 60 apartment IL, which could be also an RCAC. By doing that, we would be able to achieve and earn the revenue to support the skilled nursing, and therefore maybe not even need any type of tax levy. Go back to how we've had it in the past without a tax levy. So we're exploring that. Remember, as we march down that path, what's happening is we begin to compete with the commercial market and private. So then we have to make the determination, do we do that to stay in the business or do we get out of the business? The other option is that we close Samaritan and the long-term care facility type services for Washington County. Any questions about this?
Yeah,
Yeah.
if we were to end up closing the care in Washington County, plain and simple, where would those people end up?
Well, today, if we were to close, we would really have a struggle, and I'm not certain how long it would take. My guess is probably 6 to 9 months to find places, locations for them. And absolutely not all of them would be in Washington County. So it would be quite difficult to do that. Some of the facets that we have that, I know Jody, for example, you were looking at the latest study of predicting what should the long-term care industry look like in the future, and it's unknown. And what we're seeing is there's a lot of talk about downsizing skilled nursing. And there are a lot of components to that. When I checked with the recent industry from the construction phase and from the architectural phase, what I'm learning is new CCRCs, that's organization, that's a campus that goes from independent, assisted living and skilled nursing. What they're doing is they're either skipping skilled nursing altogether, or what they're doing is putting it in their plan for phase 2. Now that was unheard of at the time, just a few years ago, that people, organizations or companies like Ziegler to issue bonds of 100 million or more, not to have a skilled nursing in the first phase was unheard of, but that's what's happening. And some of the organizations are building 200 to 300 units with maybe 12 or 18 skilled nursing beds, knowing that you economically, you couldn't run a 12 or 18 bed skilled nursing and break even if you had to, if you wanted to. It's just too difficult, but knowing that it's going to be a loser, an outlier, but the other product lines will support it and take care of that part. So we're trying to figure out what the feds are planning to do, and it doesn't appear as though they're too active when it comes to trying to support the model of skilled nursing facilities. What they're planning on is, one, to beef up the CBRF, allowing them to care for more acute care. Secondly, what they're doing is they're rethinking home health care to the point that they will fund the family members to care for their loved ones. And that's something that's a different. And as you can see, we have the biggest single driver of the cost of skilled nursing are the regulations. And what they're doing is, instead of reducing regulations in a skilled nursing setting, they are opting to let that die and go to the other extreme where the elderly person can stay at home and be treated and cared for by loved ones with little regulations. To add insult to injury, what they're looking at in the state of Wisconsin, we are one of the few states that break our assisted living. And I'm going to get a lecture from Josh for talking too much. I can see the and Julie. Okay, but let me just make this other point. I knew that. That's why I don't look at this side. And that's why I wanted you guys on that side. So I have to look
Right here.
Yeah.
Right here.
I gotta look at the audience. Okay, anyway, we break down our assisted living into CBRF and RCAC. Most states don't. They just call it's a blend. It's assisted living. But Wisconsin has a propensity of liking regulations and micromanaging. So consequently, it drives up the cost. Well, they're shifting more residents to CBRFs from skilled nursing. But on the other hand, they're now looking at beefing up the regulations of CBRF. So all we are is, I won't be here, but someone will be here in 10 years saying CBRFs are unmanageable, too costly, and we need to go to something else. Okay, I'm gonna stop there. Yeah. No, I promise. In 10 years.
I have a question.
Yes.
What about those people that don't have family and, you know, they're Medicaid and they don't, that at home isn't an option with family members taking care of them?
That's an excellent question. And it's so fascinating because when I wanted a 16-bed unit, people thought I was crazy because I would be crazy 3 years ago. It's just, you can't run it and economically. But now what they're proposing in this 604-page report is that they're recommend building very little homes, similar to a house trailer, but very little homes so that they can care for those that don't have loved ones.
Part of the tiny home movement?
Yes.
Basically, yes.
Those old people never get in a loft bedroom.
Okay, I'm gonna stop here.
Oh,
Yeah, I know. But any other questions?
another question.
Yes.
We're gonna stop there. So these are the options that you're looking into. So what kind of a time frame do you think you have with coming up with, you know, some things that are a real viable possibility?
Okay, that's excellent. We've been looking at this seriously for over 2 years. And every time we get close to thinking this is the way to go, the feds or state change the game and the rules of the game. We're hoping to come back to you as soon as possible. One of the problems that we have is if we go down the road that we will require a referendum, and we want that referendum to be in November, we must have a final full board approval by August. So we don't have a whole lot of time if we take the approach of referendum. We may not take that approach. The board may not take that approach. I'm not certain, but anyway, that's so it's going to be sooner than later. did that answer? Okay, any other?
Can you narrow it, especially about the partnership? Are we likely to hear at the next meeting a little bit more about the possible partnership?
By next meeting, I hope that we would report on it's still on the table or it's off the table. Yes. Yes,
And all the information that was given, and Dennis and I have looked through this, and well, anyway, all of that task force did a study, and they came up with, we should stay in the business. But at that point, we were still possibly partnering, so that was out there on the periphery.
the task force said that you should build, but they highly encouraged a partnership. And back then, we were looking at 20 to 25 million. Today, the last study was 31 million. And today, I have no idea. We will go back and refresh the estimate.
On the option of renovation, 6 to 10 million. Is that, like, would there be an estimate, like number of years that might be able to take us out? And would the building meet, I guess, the current regulations, room sizes and that sort of thing? You know, it kind of sounds like with the industry changing so much, that something that looks a little more temporary or gives us an out sooner might be a good idea. You know, rather than building, and that's the commitment for what, you know, a much longer term.
Right, the couple things about that. One is, it's not the preference, the choice of preference that to do that. It's very difficult to put $6, $8, $10 million into that building and you still have an old building. The dynamics of it is that we have 131 rooms just for skilled nursing. It might be 3 less than that because we have a couple semi-privates, but so we would have to shut off wings. So it's not going to be a pretty site. It's an old building and we're putting money into it. So it's a very poor decision to make, but it's a possible decision.
Okay.
Our reimbursement by putting 10 million in, we will not be able to, we will get somewhere in the neighborhood of $3.40 a day for the capital for that, per resident.
And for some of the people that are new, and refresh my memory, but I seem to recall that we still owe money on the last renovation.
Yes.
Do we know how much that is?
It's less than 5 million.
We're down the last 2 years.
I can't,
Finance.
yeah, I don't know.
So
for sure.
something to keep in mind too.
And something you touched on, which is very important. Downsizing actually gets us more of a reimbursement.
We need to downsize. There's no way that we can't find staff now. And I have a study that shows that by 2030, we will have only the possible 4.1 possible caregivers per resident. Today, we're at the 7.2. So And by 2050 is 2.9. So we are heading for AI, artificial intelligence. We are heading for some different type of service. And I gotta get out of here because I have to face them and you get to go home.
Well, it's a very important issue and we
Yeah.
really appreciate
Yes.
all the research you've done and the input and the overview. It's extremely helpful.
Thank
It's a very important issue.
Thank you.
Can I just say one thing? So I want to remind you, or tell you that this started with 3 primary concerns. Staffing was a primary concern 3 years ago. The age and situation regarding the building and the mechanicals and the facility just in general. And reimbursement of Medicaid specifically, which is our primary revenue source and the reason that we're in the business to begin with. All 3 have gotten worse. All 3 are going to continue to get exponentially worse, and there's no signs of hope for any of the 3. So I think that's, at the end, we always have to come back to those 3 things and can we solve for them. I think you heard a pretty bleak outlook. The longer we talk about it, the bleaker I think it gets, it seems to me. And then you can certainly see why 72 counties with many of which had facilities even just a decade ago have whittled down to 33. And I know there's counties right now talking about closures. So this is a very sensitive topic. We need to be very cautious and careful about how we have the discussion and the options of which are very difficult to navigate. But those are the realities. No, I mean, that's just facts. Those 3 things, and they're not going away. So as we contemplate how to handle it as public policy makers, I think we always have to come back to those 3 things.
Right, well, great discussion for sure. We on the agenda, our next is the action items. Julie, did you want to just give us a little bit of an overview on? I have 1 or 2 comments right now, but if you would.
Absolutely. So as Doug briefly described, in our behavioral health division, we have a program called Children's Long-Term Support. And that program is designed to service children under the age 18 and under who have physical or mental disabilities. Children become eligible through an assessment, and then the services are provided through a Medicaid waiver. So children it's not necessarily income based because the services are based on the child's need. In 2017, 2019 biennium budget, the state mandated the elimination of the wait list. When I got here in 2017, we've always maintained a wait list because we could only service so many children based on the dollars that the state allocated to us. They started this waitlist elimination plan in 2018, and we have been working very hard to achieve that requirement. We added 2 staff onto the program in 2018 and 2019. And we actually have achieved the original number of children that we needed to take off the waitlist and provide services to. But what we're seeing is, if a child becomes eligible for this, the CLTS waiver, they are eligible till they're the age of 18. And so we're seeing less children fall off of the waiver and more children coming onto the waiver. So as an example, when we started our elimination waitlist plan, our full enrollment would have been at 131. We are currently servicing 231 children, and we have 50 children on the wait list. We continue to see anywhere between 5 and 8 children becoming eligible every month. We have been exploring a number of options for us to be able to add staff to the program so that we can take these children off the wait list and they can start beginning to receive the services. We originally thought that we would hire a contractor and bring those contracted staff into our building and help us to provide that service. But what we're seeing is back maybe several years ago, it was very cost effective for us to contract out because a contractor could be providing service at a lower cost than the county. What we are seeing now is that is not starting to not be the case. So we had explored an opportunity with Lutheran Social Services that it did not come to fruition. We then approached our a current provider that we use, Professional Services Group. They definitely said that they could help us with providing the staff, but when they gave us their budget, it far exceeded the cost of what it would actually cost the county to hire staff. Part of that is, I mean, they need to pay to recruit people. They need to pay in comparison to what, you know, other people are paying. But they also are looking to always make a profit, right? So they have a certain percentage of profit margin that they can make. And then they need to pay their own costs of their supervisors and their rent and all that sort of thing. So we had a conversation with the county executive around this, and he was in support of looking to come to this committee for approval to hire internal county staff so that we can be compliant and that these children can receive services. This request does not need to go to county board because of the way that this program is designed. It does pay for itself in the reimbursement that the case managers receive by their billing or their case management time. Some of the numbers are in there, but essentially at this point, we would probably receive some extra dollars or more dollars than it actually cost us to pay for staff. And every year, the hourly rate that we're able to charge for case management time, we do a financial study, so that does increase as our costs increase. So I would anticipate that potentially is a question that obviously right now we're seeing it being cost effective. But over time, as salaries increase, you could be concerned that then the county ends up paying for it. But our hourly rate that we charge is renegotiated every year based on our actual costs. I do want to note in the documents that you have is obviously the non-compliance letter received from the state and then our response. One of our concerns with the program is, I mean, while the cost of the case managers is covered because of their billing, there are other costs that go into it. The supervisor time, my time, Doug's time, billing time, that does not 100%, isn't 100% covered by this program. And that is my general complaint when I say that it doesn't truly cover the cost of programming. But those dollars are obviously already budgeted in our budget and in the county's budget. But it is a drum that I keep banging because even though we can cover the cost of a staff person, there still are, we still have to, keep our lights on and things like that. So I will stop there and see if there are questions about this request.
These are 2 FTEs, right?
Yes.
Okay. I just,
With the 2 you're adding, and the numbers you expressed on how it's growing all the time, do you anticipate any way that you wouldn't need those 2 people in 2-3 years? Or does your crystal ball say we're going to need them for the long term?
Yeah, so based on the number of kids that are coming into becoming eligible every month, we actually anticipate we'll continue to have a small wait list. We have to achieve a certain percentage with the state of a wait list to be compliant. And so, in the next 5 years, I don't anticipate not needing those staff. There could become a time over time, right, when this sort of maybe like levels out. And it could be a potential, which is one of the reasons why we had originally wanted to secure a contract, because it's easier to let go of staff or not need a staff if you have it through a contract. But again, it's something that I don't see happening, within the next 5 years. And I think for the continuity of the services, it would be most beneficial for us to have the county staff. As long as I'm here, I can guarantee you that we will continue to look at that and make sure that our reimbursement covers the cost of those case managers. Now, if it's, 10 or 15, 20 years from now and I'm not here, I cannot guarantee the next chief will look at it that way.
She's
So you're not
she's
gonna-
not gonna retire.
You're not gonna be like Matt and Steve.
At least not yet.
Good. So, on the non-compliance, I thought your reply letter was excellently, documented in many, many details, and I thought that was really helpful. I just had a couple of questions. One is, how are transfers defined? And I couldn't glean that from reading. And do we control that when someone just transfers someone to us, a different county, do we have any control over that?
No, we don't. So just as much as we don't have control as to how many children become eligible, right? Because that is a set assessment. We don't determine whether they're eligible or not. And so if a family moves into our county and they're on the waiver, then it is our responsibility to take that over and provide that service to them. Just basic proximity that we are in southeastern Wisconsin, you do see a bit of movement around your families.
Answers that, thank you very much. The other thing that I observed, and maybe I didn't understand completely, is that it appears there's a bit of duplication of services between CCS and CLTS. The way the letter was written, that it looks like sometimes some of the services are being met through one or the other. Is that accurate, or is that?
So children can be dually eligible for comprehensive community services in CLTS. So
Okay.
CLTS is really truly just a waiver. And so the case managers are essentially authorizing meeting with families, coming up with a care plan, authorizing services and managing those services. So it could be respite care, it could be adaptive devices, it could be we have many kids who go and receive therapeutic horseback riding, those types of things. So they're almost like an agent of services, right? They're not providing what anybody would really typically think of as case management, which is sort of more behavioral and more relational. When children who are on the waiver also have mental health needs and are eligible for CCS, which is also a screening, then we want to dually enroll them, because then they can get then a different pot of Medicaid dollars pays for therapy and family intervention. The way that we currently have our services set up is that our youth CCS program is run 100% through a contract, because it's all fee for service. Well, then when we have a child who's in CLTS and in CCS, the contract provider, you can only bill one. And so the contract provider gets those dollars. So we're trying to, when they're on CCS and CLTS dually enrolled, we're trying to keep those within the county so that then we can have that revenue stream rather than giving it out to our community provider. Plus, many of these children are so complex because of their disability needs and then their mental health needs, that we feel like our staff have a higher level of skill around providing that service.
Thank you for the clarification. Appreciate that. Any other questions or comments? I would entertain a motion and a second to approve these two positions. Julie has described. Supervisor Kelly and Supervisor Graff. All in favor?
Aye.
All opposed? Thank you. Our next meeting date will be June 22nd, same place, same time. And the meeting is now adjourned.